And I really, as she said, appreciate all of you who have come on time. Interestingly, it all depends on motivation and maybe, I don't know, something to do with culture, because in academy this year when I went, and there were some sessions that started at 7 a.m. and all the halls were full. So I think whether it's not a question of starting at 8:30 or 9 o'clock or 10:30, we have a tendency to be late, whatever time we start. So luckily this topic is, it's going to be more of a very short discussion because all of you know this topic very well. And I'm just going to set the stage for all the subsequent talks that are coming in. So just a brief about the pathophysiology. You know that it is a Th2 lymphocyte-driven disease. And although there are a lot of acute phase cells that come into the picture, so there's infiltration of the conjunctiva with multiple types of inflammatory cells, and predominantly we know that they're eosinophils, and then there are mast cells, and of course the T lymphocytes. That's why it's kind of a dual mechanism. So which means that when we talk about how to treat this disease and what drugs should we use, of course we all know at the bottom that we have to avoid the actual allergen that's causing the problem, so that's number one. And then lubricants and cold compressors. So that's not exactly drug therapy, but that's one of the brick on which we lay all our drugs. So the first line would be dual acting, or the antihistaminics and the mast cell stabilizers. They're kind of grouped into one category. So if you're starting off with a patient with mild disease, so the drug of choice would probably be a dual acting agent. So just using an antihistaminic alone may not be adequate, will not be adequate, and mast cell stabilizers alone, you can augment it by using an antihistaminic. So dual acting agents. Then you go to the next group, that you have a patient with a little bit more than mild, or it's despite using the agent, the patient has multiple recurrences. So you can add on disease modifying topical immunomodulators, typically cyclosporin A or tacrolimus. And then you have a patient who has more severe disease or has quite a flare-up which is significant. Then you add corticosteroids topical, which can be an add-on therapy, or sometimes it's very severe, so use it as rescue. And the other agents which you have for the very severe cases, such as systemic therapy with immunomodulators, including oral corticosteroids and so on, and some newer drugs here, as well as injections that you use, supratarsal steroid injections. And then some cases we do resort to surgery. I think Pragnya and others will be talking about some of the surgical reasons why we have to operate on these patients. So coming again a little more in more detail, the first line therapy is mast cell stabilizers. These they're slow to act, but with mild disease and prolonged use, they're extremely useful. And then antihistaminics. So instead of using them separately, you can combine them. Luckily, we have these dual acting agents, and many of us use olopatadine and some of the other newer ones. Each of us has a preference for which drug we use, but these work well for the mild cases. What about the other agents such as NSAIDs and vasoconstrictors? These don't really work. In fact, they can be counterproductive. So if you have a patient with poor surface because of EKC, you don't want to use NSAIDs because you know what is the problem with them. Vasoconstrictors have no other role except that they just decongest the blood vessels, so really doesn't help at all. And can you use systemic antihistaminics? Yes, the answer is yes. They work as adjuncts in flare-ups, and also some of them can be disease modifying, such as montelukast, which has shown to be of efficacy, especially in patients with systemic allergy as well. So amongst the adjuvant therapy, I would select systemic antihistaminic leukotriene like montelukast, none of the others. So what about our strongest weapon, which is the immunomodulators such as corticosteroids? You can use topical, we frequently have to, oral in some cases, and then I talked about cyclosporin A and tacrolimus. Then what about if you have to use medications for prolonged use? So here comes oral cyclosporin. What are the indications? So contrary to perhaps when we started off or several years ago, where we used to see a lot of patients coming in with complications due to steroid abuse. I think over a period of years, this particular problem has decreased. So the practitioners have realized that unmodified or unmonitored use of corticosteroids cause all side effects such as glaucoma and cataract, we know that. And it's still a battle with over-the-counter, the pharmacy just giving the prescription to the patient. Otherwise, the side effects due to oral corticosteroids that we see in the general community luckily has gone down. So where do we use or can use corticosteroids? Just upfront, as in literally as first-line therapy. Many indications, especially those of us who see the bad cases, so many of the moderate to severe VKC with corneal involvement and all of the findings that you see here, there are two additional indications I added. One is threat of complications, that is in especially pediatric patients with keratoconus. If they keep rubbing their eye, they'll be more prone to progression of keratoconus as well as to eye drops. And here I tend to use corticosteroids quite aggressively. And also quality of life. The child may have a mild to moderate disease, but unable to attend school, always rubbing the eyes and so on. So in these cases also, I would use corticosteroids. But most of the time, we see moderate to severe cases where we are forced to use these agents. So this is an example of a child with bilateral keratoconus, and this is different cases, but you can have patients with very severe limbal, very severe palpable giant papillae, and these patients also would need corticosteroids, otherwise the allergy just perpetuates. This is the same, one of the pediatric patients with severe VKC as well as keratoconus, which we can see in one eye, and in the other eye, the child has acute eye drop. So this can happen. How do you use corticosteroids? You can use a short pulse for the low potent corticosteroids such as FML, Lotepred, and so on, and you can repeat them. So you can use them for a few days or weeks and then stop, and then again for the next flare-up. Whereas certain other indications such as severe VKC, shield ulcer, etc., you use a more potent corticosteroids, but we have to, of course, use them as short-term. And you can augment this with a supratarsal injection of steroid in severe cases like the ones I showed you. These are various examples of shield ulcer. So different patients, again, this patient is the same as this, and these are indications for topical corticosteroids. I usually start prednisolone, and over a period of time, you see the ulcer shrinks. Of course, some of these patients, you need to surgically excise this plaque in order for a more rapid healing, and in some patients, you might even place an AMG over this plaque once you excise it. A few words on oral immunomodulators. So these are more for institution-based approach because you're more likely to see very severe cases there. And in these cases where there's a likelihood of complications such as LSCD or very recalcitrant disease, and you can use them as short-term oral steroids. Don't use it for prolonged periods of time, and usually small dose is what you can. You don't have to use the entire dose. You don't have to use, for example, 1 milligram per kg, but it's enough to use 5 or 10 milligrams a day initially, and then step it down and bring it down for a few more weeks to a particular dose. For example, typically I would keep the child on 5 milligrams for a few weeks before I knock it off. And in case you have pediatric patients or even adults where they need steroids for a longer time, then you can use systemic cyclosporin. This is, of course, you have to tailor it based on the patient that is there in front of you. You can't have a blanket protocol for everyone. So these are some of the patients needing oral corticosteroids and then going on to cyclosporin, and this is because the disease is so chronic. This is a patient who was 17, first presented with this severe disease in both eyes, and over a period of 2 years, it's better, at least, not completely resolved yet. And this is a picture. I do have pictures down the line also, and as the patient grows up and has been on 4 years of therapy, including oral steroids as well as cyclosporin, is getting under control with the disease. So topical immunomodulation, I talked about it, and we have cyclosporin, tacrolimus mixture. And coming to some of the newer therapeutic modalities, which include interferon alpha-2b, has been published as being used for resistant to steroid VKC, and the interleukin antagonists that have come up, we don't have them yet. A word about allergen-specific therapy has been proposed and has been shown in a few studies to be useful, but we have to identify the allergen. So only if we do that, we can use this, and it takes almost a decade before you start seeing a response. So if you can identify, it's supposed to be a great therapy, but not too much information on this. So that's all I had as an overview. Thank you very much. Back to you, Sharon.
Thank you, madam. Before we move on to the next talk, I'd like to invite Dr. Hitaishi Mehta, who's a dermatologist from PGI Chandigarh and has been kind enough to join us on the panel. Please. The next talk is by Dr. Kusumita. She'll be presenting a case on VKC resistant to medical therapy. And we'll have a question session after this. While we're waiting, maybe we could take a few questions.
Anyone from the audience with a question about the overall, scheme for management of allergy? Yes.
So regarding the formulation of cyclosporin that you use, so nowadays we have 0.05, 0.09, 0.1, and you also have orosporin with 2%. So when would you use what formulation of cyclosporin?
We used to use and bother about cyclosporin dosage. So in the publications, 0.1 has been prescribed, 1%, 2% also. So in Asian countries, it's available from 0.05 to 2%, and you can formulate it also. But ever since we started using tacrolimus, I think many of us, we just switched completely to tacrolimus, and I just included cyclosporin because a lot of us do use that. So it depends on what dose you have with you. And if you can formulate it, then yes, 1%. But it has its disadvantages also in terms of stinging. So you have to inform the patient that it will sting. So it's counterproductive, isn't it? If it stings and it perpetuates the eye rubbing and so on. And very often the pediatric patients. So for sheer convenience and efficacy, I've at least shifted to tacrolimus. I think many of us have shifted completely to the ointment, which is not eye ointment exactly, but we use the preparation. There's even a publication now from, I think, RP Center, where they have published their series of patients where they've used it on the upper eyelid, over the eyelid. So they've shown that it's effective.
Thank you.
So generally the 0.05, which was launched in terms of way back, the effect was much lesser. So initially we were using a 2%, but that was too toxic for the patient to manage. With the newer formulations, there are studies which say that with the nanoemulsion technique, the bioavailability is a little bit better, so it might work for VKC also with a slightly lower concentration. But like Somshila said, with the availability of tacrolimus and the cost factor and the tolerance, we generally shifted over to tacrolimus.
Thank you.
Madam, you mentioned keratoconus as a complication of vernal keratoconjunctivitis. Now, in a lot of the cases, we prefer to follow up the patients 3 to 6 monthly and then decide on cross-linking. But VKC is a scenario where we know that the progression is likely to occur faster. So, do we go ahead with first with cross-linking for these patients, even if it's a stage 1 to 2 ampular Cronich keratoconus?
Again, I would holistically look at the patient, and a few factors would help me decide as in what is the severity of keratoconus. Yes, I would be definitely more inclined to cross-link the patient. And yeah, I think I wouldn't, though I am on a podium, would definitely go ahead and cross-link the patient rather than wait and look for progression. I agree with you. So this is one of those indications where I don't even really wait once it's established keratoconus with VKC, yeah. But I would control the allergy as much as I could.
The only thing is your imaging has to be done when the eye is quiet. So if you have a lot of surface staining, that value of the imaging is erroneous. So if the patient is coming in the active phase, treat it, have a baseline. If you feel the PACI is low, you would want to do it as early as possible. These eyes, again, the healing of the epithelial defect is an issue, so you might want to be a little bit proactive. So normal healing, say in 4 days time or 5 days time, it heals. By a week, if it is not healed, I probably take the patient up to put an amniotic. I don't want a scar in the central visual axis in these eyes, and do the cross-linkage only after the allergy is under control. If that means during that phase you want to put the patient on systemic medications to control it, go ahead and do it, but don't do it in an inflamed eye.
So Prabhat, I'll just take 30 seconds because I have a slightly contrary point of view, and I'll show some limited data that I have, but I believe, and some of the colleagues that I work with believe, that keratoconus is in VKC, the problem is essentially the VKC or the ocular allergy. So unless and until you take care of that, nothing that you do for keratoconus is ever going to work, including cross-linking or transplants or any kind of interventions. So I would strongly urge everyone in the audience to focus on the allergy, and the keratoconus in a lot of cases stops progressing on its own. We don't have time today, but we can discuss later. I can actually show you some reversal of the topographic changes just with the control of the allergy.
No, it's a subject by itself. That's why I tried my best to keep the answer very brief. But the bottom line is, it's the particular patient in front of you, and you have to make your decision based on that. So that's, I think, so just like Jayesh said, even we have followed up, and we've also seen that there's been no progression. If you manage the allergy, then you do cross-linking, but the allergy continues. You will have failure of cross-linking. So many issues there.
Thank you. So, Dr. Kusumita may please start her presentation.
Good morning, everyone. I'll be speaking about the VKC resistant to medical therapy, a case and followed by discussion. We had a 17-year-old male presented with complaints of chronic itching, redness and watering, and was previously treated with anti-allergic medications with uncorrected of 6/9 in both eyes. IOP was within normal limits, and fundus was also normal. And so we diagnosed it as severe VKC and started on cold compressions, topical steroids, and anti-allergic and Talimus ointment. But there was no symptomatic improvement, nor the signs were improved at on the follow-up. So he also developed a shield ulcer along with the discharge where the inflammation didn't reduce. So we treated him as refractory to topical therapy and planned for supratarsal triamcinolone injection. Wherein supratarsal injection was planned. Here usually the needle is inserted at the superior tarsal border, and we have to find parallel to the superior tarsal border and balloon the space between the conjunctiva and the Muller muscle, which is the correct indication of use of injection. And post-operative management was given almost the same with topical antibiotic along with it in the right eye for the management of the shield ulcer. We observed there was improvement in the signs and symptoms, and flattening of papillae was noted with reduced inflammation in post-op 2 weeks. Shield ulcer also showed improvement with resolution. So this was the flattening of the papillae observed which started at 2 weeks. But with respect to IOP, there was a high rise in the IOP around 40 and 44 mm of Hg in right and left eye. Thus the patient was diagnosed as steroid responder, and he was treated on maximum anti-glaucoma medications. But the IOP still remained high despite of maximum anti-glaucoma medications for 3 weeks, and also there was a increase in the cup disc ratio. So the patient was planned for both eye trabeculectomy under local anesthesia, and post trabeculectomy the IOP was under control with no topical anti-glaucoma medications. But there was we observed there was a recurrence in papillae and the inflammation at 4 weeks post-op trabeculectomy. As there was a recurrence, the patient was though the patient was continued on all those topical medication, he was started with the oral steroids, 40 milligrams with a tapering dose, and with the rheumatologist opinion, we also started him on methotrexate 7.5 milligram weekly dosage, with monitoring of IOP weekly followed by bi-weekly with no spike noted. So at 8 weeks post-op, we noted total flattening of papillae with symptomatic total improvement in the signs and symptoms, with papillae reduced almost to totally flattened, and the patient was kept on topical tacrolimus and other medications along with the oral methotrexate once the steroids was reduced, with regular monitoring of the blood investigations and also the IOP, and the patient is still under follow-up. Now we are planning to taper off the methotrexate. So the salient features here was the 17-year-old male with both eye VKC, which was resistant to both eye topical steroid therapy, received the supratarsal injection but developed recalcitrant glaucoma, which is one of the most common side effect that we observe. Underwent trabeculectomy, had exacerbation of the VKC, and so we started with him on systemic immunosuppression. So some cases we still have to consider systemic immunosuppression. So this is one of the chart which describes the same. Moving ahead to like the supratarsal injection, as ma'am had already described regarding the indication for use of supratarsal injection of triamcinolone injections, we usually observe the improvement in the signs and symptoms within 5 days. Signs almost takes around 2 weeks to show the improvement. Repeat injections are very may be needed. Usually after 12 weeks we can it's seen in around 10 to 35% of cases. However, it also includes few complications, as we have noticed in our case. So these are the few complications. What we noticed was ocular hypertension, which is seen in 3 to 6% of the cases. Thank you.
So very nice presentation, Dr. Kusumita. Very nicely summarized about all important aspects of supratarsal steroid use for ocular allergy. Any questions from the audience for her or for anyone else on this topic? When to use, how to use, when not to use supratarsal injections for allergy?
Any role of supratarsal steroid in limbal or mixed VKC, or it's predominantly for the cobblestone papillae and the associated complications?
You want the effect of the steroids to be there locally in that site. If you have a bulbar, you'll probably get away with the topical steroids. You generally don't need a injection steroid as such. The component of the papillae causes both your immune mediated changes causing the shield ulcer, and it causes the mechanical changes which causes the shield ulcer. Also, the fact that you have GPC doesn't mean that you need to treat the patient with steroids. So generally, if the eye is still reasonably quiet, but you're seeing flat-topped papillae, you're not seeing any staining on the surface of the papillae, the only thing that will cause would be a bit of ptosis, which you will have to take a call once the patient is out of the VKC, active VKC stage of the disease, whether you want to address that or not. I think Jayesh's talk on the systemic management, and then this part would probably be well covered once I finish off my talk on MMG, because then we can put all the pieces of the jigsaw together. Coming to Somshila's talk, you now have newer mast cell dual acting agents, alcaftadine, bipotastin. You also have a higher concentration of olopatadine. Your experience on the use of the newer molecules, use of the higher concentration?
I think it depends on case selection, and they would work. Any of these would work for mild cases. I think our problem is at institutes we see more of the moderate and definitely the severe cases, and then we think that it probably doesn't work. But those in the community using more simple cases, they do say that it works very well.
So once you have a moderate grade VKC, any of these dual acting will also, it'll be an add-on to kind of continue the medication once your steroid is stopped. But by itself, if you see a significant moderate grade VKC with significant Horner Trantas dots, significant corneal staining, you might still have to give topical steroids initially. The only thing is, yes, you don't have to probably start off with a very potent steroid. You might start off with a low potent steroid also for a couple of days, because if it's not so severe, and you can continue with it. I have not seen a major difference between olopatadine versus bepotastine versus alcaftadine. I mean, I have not done a study per se, but in the patients that we have used, we have not really seen a huge difference as far as the molecules are concerned.
Thank you for a great discussion. Oh,
yeah. Can I ask one thing? What is the longest duration of topical tacrolimus that you have given ever? How many years?
Probably 5 years.
Okay, because
With-
that
with
is the
gaps
question
in
which is
between,
most
yeah.
frequently asked to us. Once the child gets better, the parents want to stop that topical.
So there is a protocol where you don't give it continuously, you do stop the medication, give them drug holidays for a while, and then when they get active allergy, you restart.
But when we start with the active, it will take again around 4 to 6 weeks to start acting. So
The experience has been that year on year, the episodes and everything go down. So you take the time you take them off the drug when you know typically you establish some seasonal variation, and take the drug off typically when you know that this is not the time that they would have allergy.
5 years is reported in literature also. I know of a patient from LBP who is taking it for more than 12 years. She is a doctor for a different indication for subepithelial infiltrates. I think your concern is mainly related to the potential adverse effects of long-term topical tacrolimus use. So maybe Dr. Mehta, you have some experience with dermatology literature, or your experience with long-term tacrolimus use, any toxicity or concerns when you apply it on the skin?
Most commonly, the patients come with burning sensation because of the application. And over long term, there's a black box warning on tacrolimus that there is risk of lymphoproliferative disorder. But the new literature which is coming up, which they have follow-up studies of 10 years and 15 years, there is no substantial risk. So we use it topically on skin for years altogether.
okay. Thank you.
we'll
The
move
thing
to
is, luckily, since the incidence and severity does to a large extent reduce with pubertal growth sex hormones which get released. It doesn't mean that you will never have a patient in the adult phase with a VKC, but the incidence and severity does come down. So you're basically looking at 2-3 years of severe activity where you want to control it. Once you cross that age, it tends to settle down. Again, if you are seeing a new onset VKC in an older patient, I would want you to look at whether there's any immunological deviation.
Right, I now invite our next speaker, Dr. Jayesh Vazrani, to give his talk on systemic immunomodulatory therapy in VKC. He has his own center called Excel Eye Care, and also the Center for Excellence in Cornea and Ocular Surface from Ahmedabad. Happy to have you here, Dr. Jayesh.
Right. Thank you very much. And basically what I'll go over is my experience at my center over the past 6.5 years with systemic immunomodulatory therapy for ocular allergy. So we do get meeting support and support for academic activities from various companies, but this has no bearing on the subject matter of this talk. So first question is why? Why do we need to look at this as a potential avenue for therapy? Because when you're talking about eye disease and disease that's just not present anywhere else in the body, why would you need to treat the patient with systemic medication rather than just topical or local or regional medication? The answer is that, as was shown very nicely in the first talk, that ocular allergy is not always innocuous. It can and does have very severe, very persistent effects on the eye. So there is actually, if you look at the classification of, for example, VKC, the end of the spectrum ends with what is called blinding VKC. So there are blinding complications of ocular allergy. We also saw that the medication that we use topically in forms of eye drops or through injections have their own set of problems. So if you keep using steroids, which are very potent and very useful in controlling the activity, you end up with glaucoma and cataract. If the disease goes on for very long, you have problems such as limbal stem cell deficiency. So we actually found out from the LVP cohort that of our patients with bilateral limbal stem cell deficiency, a very large percentage of them were due to underlying ocular allergy. This is about a third of the total cohort. And then there are other issues like long-standing allergy leads to corneal ectasia and other problems within the eye. So the first answer to the question is that it's a severe problem, and we don't always have the tools with respect to drops and injections that can deal with that problem effectively. The second most common reason is to somehow wean the patient off strong topical medication. So if a patient routinely needs prednisolone eye drops and you have to get that patient off those eye drops, in certain cases you do have to look at systemic therapy. The third is easy compliance. A lot of our patients are kids, and it's very difficult for them to keep on instilling medication again and again, so compliance becomes easy. And the fourth is the improvement in the predictability, because patients with ocular allergy are always concerned about when they will have the next flare-up of disease. The parents, if it's a child, are always concerned about that. Sometimes they even think of moving geographies for this reason. So if you can provide a treatment which gives them a predictable control of disease over a long term, that really helps in building confidence with the patient and the doctor, and the entire disease responds much better. So when do we use this? So we don't use systemic immunomodulatory therapy, as Dr. Somshila rightly pointed out, in a vast majority of our cases with ocular allergy. But it would depend what kind of practice you have. So in my practice, usually the cases that we get are those which have tried and failed other forms of treatment for a very long time. So if you are seeing what is at the top of this very nice classification that came out in IJO recently, not very recently, there's a recent upgrade to this. So if it is refractory disease, vision threatening or blinding or severe disease, you would definitely look at systemic immunosuppression. Also because quite a lot of these patients will need some form of surgical rehabilitation. So for example, if you're doing allogenic limbal transplants for these patients, if you're doing keratoplasty, some cases keratoprosthesis for these patients, they will need to be on systemic immunosuppression. So it's that subset which needs the treatment, not all other patients. So severe or blinding disease, as I said, will typically be patients who have all these secondary complications of either the disease or the treatment. In addition, I will specify that patients who do not have blinding disease, let's say patients who have moderate, intermittent or moderate persistent disease but are steroid responders, like Dr. Kusumita showed. So there, this is a very good option. Like they logically went on to have systemic methotrexate as part of their treatment protocol. I completely agree. So steroid responders are another cohort where you would use this even if it is not blinding disease. How do I use it? Well, if you look at the pathogenesis of the disease, and I think Dr. Abha will show some basic research work on this, it's basically a T-cell mediated disease. So my drugs of choice have always been the calcineurin inhibitors. So early on I used oral cyclosporin. So this is the pathway and how the inflammation is mediated. But basically if you manage to tackle the T cells, that take care of all the downstream issues with the disease. So one could argue that this is a very broad spectrum way of treating it, or a bombardment, and it's not very specific to the cytokines that are present on the surface, but it works, and this is what we have right now. So there is some literature, some case reports and case series for the use of systemic therapy in atopic eye disease. That is, let's say VKC, similar picture with either skin manifestations, respiratory manifestations, and there is some literature in that, not so much for isolated eye disease. So what is our experience? Our experience, well, these are patients who are followed up for a minimum of 6 months. And this is a subset of the data which I am showing only the adult patients, because we are still looking at the data set in our pediatric patients. We first started off using it in adult patients, and the pediatric patients we have started off a little later, so the follow-up is less. So we now have 12 patients with a minimum follow-up of 6 months after initiation of therapy, about equal male and female. And you'll see that the median age is 24. The median duration of disease is 9 years. So they've had disease ranging from 5 years up to 30 years. And the severity score, so mild, moderate, quiescent was 0, and then you have mild, moderate, and severe and blinding diseases clubbed as 1 into grade severity score 3. So all of these had the highest possible severity score at initiation of treatment. And very few of these, just 2 of these patients had some form of systemic manifestation of atopy or allergy. The rest of them were all isolated ocular disease. All of them had comorbid conditions in the eye. A lot of them had keratoconus, a lot of them had cataract, some of them had glaucoma, scarring, other issues with the eye. So this is how we start treatment. The treatment is always initiated along with a course of oral prednisolone, which you taper off over 6 to 8 weeks. Earlier, let's say from 2017 to about 2020, we used cyclosporin. And now, because tacrolimus, the generic forms, are as cost effective or slightly more cost effective than cyclosporin, and it is much more efficacious, we have shifted to oral tacrolimus. And if you notice the dosages, you will notice that these are doses that are much, much lower than, for instance, doses used for organ transplants or other indications, systemic indications. So tacrolimus these days we use anywhere from 1 to 4 milligram per day. Cyclosporin I used to use 2 to 4 milligram per kg per day. Right. So about half of our patients were on cyclosporin, the latter half in the, let's say the past 3 years were on tacrolimus. One patient we had to shift to mycophenolate because of toxicity concerns. So with this, we achieved remission, a completely quiet eye free of any disease activity in all of our patients. The median time taken to achieve remission was 3 months. And if you look at the long-term data, out of those 12 patients who have more than 6 months of follow-up, 11 of those have a follow-up of a year or more. The oldest patient we have has now a follow-up of 6 years. So it's pretty good. The relapse-free survival, I can confidently tell a patient when I start this therapy, which I could not say 5-6 years ago, that I'm going to start this treatment, and 8 or 9 out of 10 cases it works, and it will keep your eye quiet of the disease. So that confidence is important to have, and that is what we get from this data. That it works, and it works in the long term. So at last follow-up, we did not have to use topical prednisolone in any of these patients. We had to use a small dose of oral prednisolone in 3 of these patients and topical loteprednol as and when needed for seasonal exacerbations. None of the patients with keratoconus progressed. Glaucoma progressed in only 1 patient, and the eye was quiet in 10 out of 12 patients at last follow-up. The visual acuity improved considerably because we were able to do cataract surgery, give them contact lenses, so that's why the visual acuity improved. We had transient elevation in liver enzymes in 3 of these patients, and 1 patient hypertension, but none of them had to discontinue therapy because of adverse effects. We have managed to stop the therapy in 2 of these patients because the disease is now quiet, and 1 patient was not able to follow up and monitor, so we had to stop therapy. So my take-home message is that systemic immunomodulatory therapy has a definite role in a certain part of the spectrum of this disease. Even for isolated ocular disease, you need to select your patients carefully. You need to be well versed with what you are doing, because I was fortunate to train at PGI during my residency, and then with Dr. Virender Sangwan at LVP, where we do all this medication ourselves. If you can't, then please collaborate with a physician or an immunologist or a rheumatologist. There are practical difficulties. The main difficulty I feel is the mindset of the treating physician, or the reluctance to use systemic therapy, because as eye doctors we are not very well trained to use it. So we are not very familiar or comfortable with it. The other issues are counseling the patients about the different aspects of follow-up and monitoring, and relative lack of evidence, as I pointed out. So thank you very much for the opportunity to speak. And on this topic and on various other ocular surface related topics, we have a very nice workshop which has been going on for about a decade now almost at Hyderabad at LV Prasad. And I'm pleased to tell you that next year the ocular surface workshop is being hosted at Ahmedabad in September. So I invite you all. So if you want to explore this topic and other topics, it will be a very nice, informal, very different meeting. So I hope you can join us. Thank you.
So a few quick questions we can ask. Yeah. Sir, what is the minimum age for which we can give systemic immunosuppression?
Right. So in this
cohort, and for how long?
Right.
Second. And the third question is, what is the medical legality for? Can we start on our own, or do we need to tie with the rheumatologist?
Are you a doctor?
Yeah.
Yeah. Then you can use medication.
Yeah.
Right. That's the first thing. The second thing is these patients were all adults, so minimum age was 18 years. We have now started using it in the pediatric age group. I happen to have a friend who is a very good pediatric rheumatologist, and I talked to her about this. So they use it for various indications for very young kids. For example, for JIA, for nephrotic syndrome, for other indications, even young kids can be put on these drugs. So that's not an issue. The youngest patient I have would be maybe 6 years old.
Because sir, I have a kid, I have been managing since 3 years and have given him everything, and he repeatedly keep on developing shield ulcer.
Correct.
The time I stopped topical, so I was thinking.
I think it's an ideal indication for your patient.
Thank you so much, sir. Thank you.
Right. Yeah, maximum follow-up is about 6 years. That I have personally, but I can tell you from discussions with, let's say, Dr. Sangwan, he's been using it for more than 15 years. So your intent is not to keep the patient on the therapy for 15 years. Those are exceptional circumstances where they've undergone limbal transplants or something where they need it for a longer term. But as I showed you, we have now started taking off our earliest patients because the disease has been quiet. So my criteria is if the disease has been quiet for a minimum of a year, then we start reducing the dose, and the goal is to get them off treatment.
So during the follow-up for these patients, are we getting almost no recurrences per year as compared to maybe 3 or 4 recurrences?
Correct. So if you talk to Dr. Sayan Basu, he'll share a graph with you. They've been using a different form of systemic therapy at Hyderabad now. Well, they'll show you the dampening of the recurrences. So there's one line which goes up and down, up and down, up and down, the seasonal variations. Patients who are on systemic therapy, it's a flat line.
Sir, it is my understanding that the uveitis specialists prefer methotrexate because of the safety profile for pediatric population. So is that a preference for you, or you continue to use tacrolimus?
I have not tried methotrexate for ocular allergy, so I really cannot tell you, because my rationale was that these drugs work well on the surface when given topically, so they should work well systemically.
And as a dermatologist, you all prefer cyclosporin now for an atopic dermatitis, or you prefer tacrolimus now?
We practically never use systemic tacrolimus. We give cyclosporin in children above 6 months of age also, but practically we never use tacrolimus.
Reason why you don't use tacrolimus systemically?
It's mostly physician comfort related only, and even if when you look at the guidelines for atopic dermatitis, all of them recommend cyclosporin only.
And is it because you don't need to use? I mean, your topical therapy is very effective, and that's why you don't need to go to systemic therapy in a lot of cases.
So patients who have moderate to severe disease, there definitely we need to give systemic medications.
So use systemic cyclosporin.
Cyclosporin.
Right.
Another small caveat is, it may or may not be related to the discussion here, but serum vitamin D deficiency has been a major consistent, and it has been established in literature as well that it is associated with VKC refractory to medical therapy. So prior to starting systemic immunomodulators, has there been any substantial evidence to work up for nutritional causes? Because there has been literature showing that these children spend very little time outdoors because of that photophobic and that fear to send them outside, etc. So is there any role of nutritional causes prior to starting on systemic immunomodulators?
It's a very interesting hypothesis about vitamin D and various diseases, not just in the eye, but all over in the body. Okay. But personally, I have not looked at vitamin D levels in these patients, so maybe if anyone else has any experience with that.
I don't think we have the answer to that at this point of time. Even for dry eye, we are now understanding that there seems to be a role of vitamin D,
correlation,
but our understanding still needs to evolve.
Okay, thank you.
We now have Dr. Nitin, who will be speaking on sublingual immunotherapy in VKC.
Good morning, everyone. So, thank you, Sharon. Thank you, Bhaskar, and Jayesh for including this. So, sublingual immunotherapy, and first let me say that the perfect person to give this talk would be an allergist or a immunologist, pediatric immunologist. However, I'm very lucky that we get to work very closely with this team. My wife is a pediatric allergist and pulmonologist, and she works at a hospital very, very close to us, along with Dr. Ankit Parak. So, what is sublingual immunotherapy? Is a desensitization treatment where we are trying to get these patients to not have allergy anymore. The promise is really big. I think a lot of the load of ocular allergy, a lot of the problems of ocular allergy are